Dear ladies and gentlemen, colleagues, welcome to already the sixth session in which we address what is arguably one of the most consequential strategic questions in structural heart disease today. When we implant a transcatheter valve in a younger patient, does the choice of the index valve will define outcome and future reinterventions? As TAVI extends into lower risk and younger patients, the decisions we make today will have implications that stretch years ahead. This session brings together some sharp minds, and it's my pleasure to co-chair with Thomas Modine. Thomas.
Thank you, Nicolas. So with Nicolas, we're going to co-chair this session, and it's my immense pleasure to invite and present the panelists. The first, of course, is Joanna Wykrzykowska, David Hildick-Smith, the one and only, and of course, Roy Campante Teles. So together we have four presentations that build on one another to give us a comprehensive picture. We're going to cover, of course, durability, but from durability data to device design to reintervention planning and to anatomy-guided selection, we will be able to discuss the insights from this very important topic, which turns around durability. So without any delay, I would begin by inviting Nicolas van Mieghem to present. And the title of his talk is Current Insights into Valve Durability and Need for Valve Reinterventions. Nicolas, you have 5 to 8 minutes.
All right. Thank you very much, Thomas. So I'm going to give you some updated insights into valve durability. And this is a slide by Julien Ternacle from Bordeaux, where he basically summarizes the differences between structural and non-structural valve degeneration and what affects it. So for non-structural valve degeneration, it predominantly revolves around issues related during the index procedure. We end up with a paravalvular leak, or we have prosthesis-patient mismatch. That basically is present from the get-go at the index procedure. With structural valve degeneration, other things are at play. Younger age at the moment of the device implant plays a role. Patients with diabetes, uncontrolled diabetes, or chronic kidney disease, those are factors that may expedite valve degeneration, structural valve degeneration, which is based on inflammatory and immune processes, and that will result in calcium deposition, fibrosis, and other issues that may eventually lead to a valve obstruction or valve regurgitation. So the good news is that so far, out to 5 years, these transcatheter valves, as compared to surgical valves, have been basically on par. So if you look at hemodynamic valve performance out to 5 years, there's no difference between the self-expanding evolute valve, so the supraannular functioning valve, and surgery, or between balloon expandable valves and surgery. If you look at another valve system, that is, for instance, the intraannular functioning self-expanding valve, if my slide will move, there you go. So then we're talking about Portico and Navitor. You see that the hemodynamic valve performance strikingly is similar for the smallest valves, the intermediate-sized valves, and the larger valve sizes. So that is quite an interesting feature that is quite unique to this valve platform. And if you look at bioprosthetic valve failure out to 5 years, this self-expanding intraannular functioning valve has no reports of bioprosthetic valve failure. So these are quite promising results. Now let's look beyond 5 years. In the NOTION trial, we have follow-up out to 10 years. And there, the core valve is basically, again, on par with surgical valve replacement in terms of structural valve degeneration. Core valve is a first-generation valve platform, but we have to bear in mind that in NOTION, the mean age of the patients was 79 years old. That means that there is a competing risk of death, all-cause death or cardiovascular death. So at 10 years, it becomes more and more difficult to interpret valve durability data because so many patients in NOTION 3, 2/3 of the patient population had died. So you don't have that information on valve durability. If we can go to the next slide, then we go to more recent data. For instance, in partner 2A, that's an intermediate risk patient population. Again, a mean age of more than 80 years old. At 10 years, there is no difference in mortality, but the mortality is high. More than 80% of the patients have died. So again, you have that competing risk. So it's difficult to interpret durability. But here already you see that after 6 years, all of a sudden you see more reinterventions with the balloon expandable valve versus surgery. But this was an early generation balloon expandable valve. With the contemporary balloon expandable valve, the S3, we do not see this increase in reinterventions after 6 years. Although again, bear in mind that the majority of the patients were more than 80 years old, so the competing risk of mortality has some effects on the interpretation of this data. Therefore, it is very important that we now have 7-year data from partner 3, that's a low-risk patient population. The mean age of those patients, 73 years old, so only 20% of the patients had died by 7 years. And here you see again that there is no difference between the balloon expandable S3 device and surgery. A different story is seen in the evolute low risk. We have to consider that in evolute low risk, early generation self-expanding valves were being used. So we're talking about CoreValve, and in the majority, the Evolute R platform. So no sealing wraps in that particular study. You see no difference in mortality. Again, more or less 1 in 5 of the patients had died by 7 years. But you do see an increase in reinterventions in the transcatheter aortic valve implantation arm that starts at 6 years and becomes significant at 7 years. Why is this? The dominant mechanism was aortic stenosis, was aortic regurgitation and not aortic stenosis, and that helps us with a potential explanation why we see an increase in reinterventions, and that has to do with the concept of post-dilation. You see that we saw more reinterventions in the patients that had larger valves being used. And in those patients, when they were getting post-dilation, balloons were being used that were much more oversized than we typically do today. As a matter of fact, Medtronic issued a modified or a new and updated instruction for use for post-dilation that recommends against the use of major oversized balloons for post-dilation. Unfortunately, during this trial, that was not applied. And so you get the use of oversized balloons, and that resulted in micro tears and macroscopic tears in the transcatheter valve leaflets. And this has also been demonstrated in benchmark testing. If you use the current instruction for use, if you apply that, then you don't create micro tears. If you use oversized balloons, that is where the damage to the leaflets occurs, and that damage occurs from the get-go during the index procedure. So there are some consequences, and the good news is that we have identified some of the reasons why we see this phenomenon, and that we have made adjustments in the last 5 years. Now, what is this risk for revalving, the need for revalving procedures? Now, this is data from the surgical space. Well, we are all familiar with the concept that the younger a patient is and receives a bioprosthesis, the higher the likelihood that the valve will degenerate. So structural valve degeneration happens at a faster pace in younger patients. But still, let's put those data in perspective. Well, if you get a surgical bioprosthesis at the age of 70 years or 75 years old, the risk for a reintervention is less than 10%. If you get a surgical bioprosthesis at age 65, the risk is still less than 20%. So I'm not so sure whether we need to be overly concerned about bioprosthesis at an age of 65 or 70 years old. But it is relevant to consider that structural valve degeneration might happen in approximately 1 in 10 to 1 in 5 of the younger patients who get a surgical or transcatheter bioprosthesis. And this is where simulations may come into play. Based on CT studies, we can do simulations of lifetime management. We can determine how a valve will look like once it is implanted, but also how a revalving procedure would look like. And this is a very interesting concept because you can simulate sequential revalving procedures. And we have done that in several cases. And this is a beautiful example of a patient that required 3 sequential TAVI procedures for valve degeneration. And we ended up with a problem because after the 3rd valve was implanted, the valve area had decreased from 420 millimeters square to 300 millimeters square. So we had a 30% reduction in the area, the annular area. And basically that patient ended up with prosthesis patient mismatch. So that tells you that yes, TAVI and revalving and another TAVI procedure may be of interest, but there are some limits with adding metal layers after layer after layer, because it will come with reductions in annular areas. And on top of that, obviously, we also need to consider coronary obstruction and other issues related to multiple valve implants. So with that said, I think that we are in the era of transcatheter valve therapies in 2026, but that doesn't mean that surgery is out of the question. As a matter of fact, I think in younger patients who are considering treatment for aortic stenosis, they can definitely be treated with TAVI first, but they have to be informed that at one point a surgery might be relevant. And then I'll get to my final slide, I hope. So let me see. So I wanted to conclude that non-structural valve degeneration exists from the index procedure in the majority of cases and should be rare in 2026 because we have optimized sizing algorithms, better valve selection, and proper implantation techniques. Structural valve degeneration is unremarkable up to 5 years, but beyond 5 years, it varies per valve platforms. And earlier valve iterations may suffer more from structural valve degeneration than the newer valves, and also optimized implantation techniques may prevent structural valve degeneration down the road. And I do find these lifetime management simulations by CT of interest, and they may even complement patient counseling. With that, I give the word back to you, Thomas.
Thank you, Nicolas. Excellent presentation, very clear as usual. That will set the debate. So let me start by, we have 3 questions from the audience, and 2 of them turns around the same thing. So I don't know who want to pick this one, but at what age or risk profile do you feel confident offering TAVR as a first strategy, knowing the patient may need valve-in-valve procedure in 10, 15 years? Let me ask Joanna, ladies first. If you want to, based on what Nicolas have said and what you are going to tell us afterward, what do you think about this question?
Just it's life expectancy, right? It's not just the age itself. But I think between 70 and 75 is somewhere the sweet spot, right? I think we know that most of our European patients survive at least 10 years. And so our longevity of our valves, we know, is fairly good up to 10 years. I think it all has to be based on anatomy. If you have severely calcified valve with bicuspid anatomy and big chunks of calcium, when you know you will not get an optimal first TAVI result, you'll get under expansion, perhaps it's the time to ask the surgeon to treat the patient. But anyone above 70 that has fairly simple tricuspid anatomy, I think, can be treated with TAVR.
So let me push a bit further this question. David, this is for you. How do you feel counseling a 65-year-old gentleman or a lady and having a kind of trade-off decision to make between balloon expandable and self-expandable based on what Nicolas have shown? I mean, we have partner 1, partner 2, partner 3, evolve with low risk, and the current data. What do you think about this? And how can do we have enough data today to make a clear decision or not?
That's a tricky multi-part question. So firstly, I mean, somebody 65 will only really be getting TAVI in our place if they're not suitable for surgery for some good reason, and if their life expectancy, as Joanna said, is perhaps limited. If they're then going to be a one-valve patient, it may not matter that much, and you'll base your decision on the actual anatomy itself. I'm not sure that I would place too much weight on the apparent differences in longevity of the 2 valves. I'm a little surprised by the core valve data that isn't sort of personal experience. And I think in some respects, a balloon expandable system may be expected in the smaller annulus to last less well, of course. So I think it's very much, you know, if you are going to face a 65-year-old who's having TAVI, you base it really very much on the anatomy. I do think we should always make our choice based on what the patient needs now rather than what they will need later. Yes, we should bear in mind what they might need later, but we also have to bear in mind only 5% of them may ever come to have a second valve.
Thank you, David. Time to move forward now, and it's my pleasure to ask Joanna for her presentation, which is more or less also related and an extension of what we have been discussing a little bit further before. Design considerations related to transcatheter valve durability. Joanna, the word is yours. Thank you.
Thanks for having me. It's a great pleasure to be here with this audience and panel. So what Nicolas just told you is that durability in all the trials and registries of the TAVI is actually the same as SAVR, perhaps even a little bit better in some of the studies. And we have data from NOTION trial up to 10 years, of course, with older devices still, and perhaps patients that are a little bit older. But we know from partners 3 data that up to 7 years, there's only 7% risk of structural valve deterioration, stage 2 or 3 in the patients, which is fairly low. Again, same for SAVR and TAVI. So why worry? Now, we still have to be on our toes, and I think we should not rest on laurels. A low-risk Evolut trial gives us a little bit higher reintervention rate at 7 years than SAVR due to mostly aortic regurgitation, possibly due to this more aggressive predilation outside of the IFU, but perhaps not the whole story. And a lot of these patients actually ended up having operation and explant of an Evolut valve. Of course, the stroke rates and 6-year mortality were very similar. We know from the burn registry also that if you have structural valve deterioration or hemodynamic valve deterioration early, then it's a potent predictor for later on having reintervention rate. It's actually a hazard risk of 5 times. And of course, burn data is also a little bit limited by this competing mortality risk at 10 years. So just to focus on the bioprosthetic valve dysfunction, I think Nicolas also explained this, and I will mostly focus on this part. What are the mechanisms of the structural valve deterioration? So mechanical stress on the leaflets, and it can be enhanced when patients are younger and exercise more, etc. But also disturbed valvular flow patterns, and they can have to do with your initial deployment of the valve. If the valve is not completely symmetric and your flow in the valve is not completely laminar, not restored laminar flow. That can lead in turn also the inflammation that occurs then and immune rejection process can lead then to valve leaflet thrombosis, whether it's HALT or whether it's actually severe thrombosis, and then really severe structural valve deterioration, then requiring a replacement. So you can, of course, treat the consequence or treat the symptom in some way. So popular Atlantis trial of Württemberg, which is currently enrolling, and we're participating in this trial, is taking patients and doing CT-guided versus standard of care treatment. So after valve implantation at 3 months, patients get a CT scan. Half of the patients get the CT scan. And then if there's no HALT, they even can stop aspirin if they have no other indication. But if they do have evidence of HALT, they actually get put on low dose apixaban to see if we can reduce this and also prevent both strokes, clinical endpoints, and also reintervention. And I think what we'll probably see, so of course you have to wait till the end of the trial to analyze this data, but a lot of the patients probably that have this HALT also have some evidence of non-tubular valve placement and under expansion. And we know from the accurate data, which of course this resulted in also increased stroke rate. But when you have a non-tubular shape, when you have this tapered or flared shape, you have much higher risk of reintervention. You have a higher risk of pacemakers, you have a higher risk of hemodynamic deterioration, and also paravalvular leak. So this is something that we really have to pay attention to at the first stage. And so for balloon expandable valves, you can also measure the expansion index, and you can do the double tap technique to improve your expansion and prevent perhaps some of the problems that result in this, especially in the small prosthesis. In the OPTEX trial of Ole de Bakker, this premise of under expansion leading to HALT is sort of the basis of the trial design, where actually patients at the index procedure get randomized between a very active pre-dilation, proper sizing, and more aggressive post-dilation versus standard of care to see if we can modify the risk of HALT. And then, of course, you come to valve design, this whole issue of inflammation and also laminar flow, right? So the Duravar technology, which is sort of a new kid on the block and is now being tested in the Paradigm IDE trial, that valve is not only decellularized and has lower inflammatory index, but what it does more importantly is that it restores completely laminar flow because of longer coaptation of the leaflets. And with this, not only do you get better hemodynamic results potentially, but as is shown in some of the preliminary data, again from Ole de Bakker's group, is that this reduction in turbulent flow is associated with faster LV mass regression. So you can actually affect probably also heart failure outcomes in these patients and LV remodeling, which is very interesting. And last but not least, Navitor valve design, also a tubular valve design, self-expanding platform, intra-annular, but again, non-tapered, there's no waste here. You have equivalent inflow and outflow, which from the engineering standpoint would also probably result in more laminar flow and better hemodynamics. And indeed, Nicolas has shown us in the Vantage trial of 400 patients, again, low risk and intermediate risk, that this platform not only has only 2% risk of combined endpoint at 1 year, but it has absolutely no moderate to severe PVL, and it has excellent hemodynamics early on and at 1 year in the single digits gradients. So that's very promising. Of course, this is further being confirmed in the Envision IDE trial that's currently running in the US and also in Europe. We in UMCG included the first European patient on the 8th of April in the trial, and the patients who are a bit younger and also lower risk, so with higher life expectancy, will be followed with echo for 10 years to look at the issue of SVD and durability. So just to conclude and get us up to speed in terms of time, we have similar rates of SVD in TAVR and SAVR patients. When you have hemodynamic valve deterioration early, it is associated with higher risk of reintervention. And then I think the issue is, how do we prevent this from happening? How do we improve the durability? Anticoagulation is perhaps one thing, but I think optimal symmetric expansion of your valve and also novel valve designs with tubular design and also restoration of laminar flow. So thank you for your attention.
Thank you, Joanna. Excellent presentation again. I have a lot of questions, but we have also a lot of questions coming from the audience itself. I mean, you have shown in one of your slides, Joanna, that there is no significant difference from any trial between the platforms we have available today. So is it because it's too early, or because these valves are changing, or this is the reality of this therapy? And rather than focusing or discussing about the shape of the platform, we should more see which valve is better tailored to the patient itself? Because this is something we are tempted, all of us, to say, oh, this one is better. Is it really anyone which is better than the other one?
Yeah, I think we have to show this in device-to-device trials, right? So we've done the TAVI versus SAVAR. Now we're starting to randomize patients like in landmark trial, Merrill valve versus workhorses. All the IDE trials are randomizing against the workhorse. I mean, I think in my own practice, I also make decisions based on patient initial anatomy and on the CT scan. If we have small anatomy, then you reach for a self-expanding platform. If you have severe calcifications in the LVOT or pacemaker risk, you reach for a balloon expandable platform. But I think this is a little bit of an older way of thinking, because if you start getting balloon expandable platforms with better hemodynamics, or self-expanding intraannular valves with better hemodynamics, then there won't be as much of a difference in terms of small versus large annuli, right?
Good. Roy, I have a question for you. I mean, you are one of the most visible cardiologists in our community. So how all these data impact your practice? I'm going to be more challenging. Does the increase of TAVR use in younger patients changes the way you approach surgical conversation with your surgical colleagues? Are you now recommending different, or pushing for a type of surgical valve? Are you still discussing the patient with your surgeons or not? This is from the audience, it's not from me.
Yeah, good. And it's an excellent question. Thanks for this one. I believe that at this stage, we don't have yet enough data to make the big change towards TAVI in very young patients. Therefore, in my mind, if I have a patient that is younger than 70 years of age, I would have always discussed this patient with my surgical colleagues. Of course, sometimes patients do their own individual choices and they pressure us so that we move up towards a TAVI procedure. And in those cases, of course, if the patient has a good anatomy, a favorable anatomy with no LVOT calcification, good coronary access, etc., I think we can, of course, accept TAVI procedure as long as they are aware that there is a second or third intervention in their future. But if for the time being, I think we don't have enough data to support it, we should move in very young patients towards TAVI first. I think we should still discuss the patients with our surgeons.
Okay, maybe
Nicolas.
to add to that, Thomas, I think in this discussion, what is missing in general is that the concept of CT planning should be strategy agnostic. That means that every patient with aortic stenosis needs to undergo a CT scanning for proper planning. And also younger patients, they need a CT plan because that will help the heart team in selecting the best strategy. And sometimes the best strategy is TAVI, also for younger patients, because it depends on the anatomy. It happens time and time again that surgeons open up the chest and are confronted with a porcelain aorta or with another reason why they don't proceed with a valve replacement. And that is a pity these days. And there's also a flip side. Some patients may be very aggressive in their demand for TAVI, but then a CT scan may help us convince what the proper strategy is. And sometimes that is surgery. So I do believe that all our patients require a CT upfront, also the younger patients.
One last question. I'm a bit disturbed by the outcomes of this latest the data from Evolute sur TAVI related to the post-dilatation. And you see we have now more kind of trend to post-dilate again and again. Joanna has been showing the slide where for Edwards, where it's not recommended to do this double tap, and some other platforms, we have a tendency to post-dilate here and there. Don't you think, and this is a risk we are taking without real supported data behind, that could damage the leaflets, as we have been saying for a long time in the beginning of the TAVR experience. Remember in the beginning, we used to post-dilate almost everybody. we stopped doing this because we have been fearing damaging the leaflets. And now we have a study that confirms that. Don't you think that there is a lesson here to learn? Who wants to pick this one?
I think I showed the data, so I might have to defend it. It's still a question. I think I think the post-dilation problem potentially was with overstretching, right? So not observing the IFU and post-dilating with too big of a balloon and damaging the valve leaflets that way. And the jury is still out precisely what the reason was in the Evolute low-risk trial. I think you want to achieve the best result for the patient. I mean, in my own practice, I must say I predilate almost everybody, especially in the self-expanding valves. But post-dilation, indeed, it has some drawbacks. Higher pacemaker risk of embolization, damage to the leaflets, as you said. So I think in our own practice, it's no more than 20%. Only if you have clear evidence of asymmetry and a gradient do you post-dilate.
Thank you, Joanna. So, Roy, it's time to move on. And I would like to invite you to give your talk on the impact of index valve selection on future feasibility of reintervention. Thank you, Roy.
So, again, thank you, Thomas and Nicolas, for inviting me for this marvelous course. So my topic today is to talk about the impact of index valve selection on future feasibility of reintervention. Just a moment. Okay. So, of course, reintervention feasibility is clearly becoming relevant. In our series, we did the first case in 2024, and the number of patients that are coming back for intervention is increasing here and elsewhere. So it's really a hot topic. Having said that, so I'm not able to move forward with my slide now. Oh, sorry, takes a while. So what are the factors that affect intervention or reintervention in these cases? So we have factors that are related with the patient. Of course, I'm talking about the aortic valve complex. I'm talking about coronary takeoff and orientation. I'm talking about the annulus size and calcification. And I'm talking also about the membranous septum shielding. On the other hand, if we consider other important topics, there are device-related topics, the ones that are related to the stent frame height and geometry, the super versus interannular position of the leaflets, the porcine versus bovine leaflets, of course, and the commissural orientation. And all these factors are important for reintervention. Having said that, what are actually the device factors that we can consider and that will frame any possible reintervention and are important for the feasibility of that reintervention? First of all, on the left, you'll have the two balloon expandable or short frame valves, and you can, of course, understand that there are important fluoroscopic landmarks that will that are related with the top of the deflected leaflets, which are at the top of the frame. And if you go for the self-expandable valves for the navigator, that is at the bottom of the commissural tab, while in the core valve is in node 4, 5, or 6 for the Evolute. Then if you consider the nadir of the leaflets, which is the black arrow, that the nadir of leaflets is 2 to 4 millimeters above the inflow in the short frame valves, while in the navigator is at node 1, and in the core valve it's not 3. And this is important because it will, of course, determine the strategy of delivery to the first device. Because, in fact, the first valve choice is critical regarding future reintervention. And the ideal redo procedure depends on a proper device selection and sizing. But what is the ideal redo procedure? It's something that we determine according to the patient's profile. And of course, we are always talking about, as we discussed before, young patients with low risk. And the main features that we're going to discuss around this are related with the coronary risk. We want to have patients that have low coronary risks. We are also related with the option to avoid leaflet overhang, to achieve perfect hemodynamics, and to ensure that there is no annular injury and that we have a lifelong durability with no PVL. In that regard, of course, there are different options. And if we consider, first of all, the coronary risk, I think we can select valves that are short frame valves or large or tall frame valves that have large shells. If we want to, we fear LVOT injury, of course, we're going to play with the implant height and we will select self-expandable valves. If we want to avoid the leaflet overhang, we usually will select intraannular devices, cylindrical intraannular devices, and to avoid the second short and tall valve. If we want to achieve a perfect hemodynamics, I mean a patient that are in the extremes of body weight, or when the area is below 400 or the perimeters is below 70, in those patients we want to maximize the effective orifice area, and therefore we're going to opt for a supraannular device. And finally, if we are talking about lifelong durability and balloon and PVL, usually the balloon expandable valves are the ones that we can select. Having said that, that means that the first valve choice will, of course, affect feasibility in the long term, and we have to have a good start. And that good start depends, of course, on the device and sizing, as I mentioned, but also on the performance of the operator during the implant. So commercial alignment and the implantation depth are critical for a good results regarding the reintervention. And in that regard, we have to consider that there is some data that will help us to, of course, consider what are the options. And in that, the data that is out there shows, first of all, that the first valve that we choose does not affect actually the success and the safety of the secondary intervention, although the secondary intervention, the second TAVI valve, plays a role here, because the second TAVI valve usually, as you can see on the right of your screen, the second TAVI valve, if it is a self-expandable valve, will allow to reduce high residual gradients from 24 to 11%, and that is translated in a higher success. Although the first valve, as I mentioned, does not affect the success of the second valve. Again, then we have to consider the coronary risk for recannulation. That can be high, that can be different according to different platforms. And in that regard, we have on the left, I hope that the slide moves on because it's taking a while today. But anyway, on the left, you'll see that the short frame valves are the ones that have usually a better potential of re-engaging the coronaries compared to the tall frames with larger cells, compared to the tall frames with with short cells. I cannot move forward my slides at this stage. I don't know what's happening. Okay, here they are. And what is important to stress out is that in the end, the number of patients or the percentage of patients that can actually be where there is an unfeasible cannulation is very low regarding the left main, although of course this, as I mentioned, is different between different valves. In what concerns also this study that was published by Giuseppe is that, as I mentioned before, the moderate severe misalignment and the implantation that are critical for recannulation. And of course, the selection of a high THV also affects that factor. The other point is that if you are aiming for a short valve, then you have to know that the nose skirt should be smaller than the coronary height. And that, because if that doesn't happen, of course, the risk of coronary occlusion is higher. But again, then if you go for the self-expandable platforms, the scenario is slightly different, because in that scenario, we will play a lot with the depth of implantation to avoid the coronary risk. And here you can see that in this paper, that the percentage of patients that have an intermediate to high risk of coronary difficulty in the re-engagement in the Navitor platform is only 7% compared to the Evolute on the right, which is 32%. And that is in a low implant. If you go for an high implant, you still have difficulties with both platforms. And so it's very important to select the proper depth of implant in the self-expandable platforms. So to conclude then, as my take-home message, what are my thoughts about the first choice when we have a patient with a low risk and young patients? First of all, the coronary occlusion risk is my major concern, as well as the hemodynamics. Regarding the coronary risk, I think that the internal annular devices are the ones that provide more options for the future. Regarding the patients where there is a small annulus, on those patients, I think the platforms that are better are the super self-expandable valves. If you consider then the other problems that we have in our minds related with longevity, we will consider in those cases, the slides do not advance at all. I don't know why, but anyway. Okay. So regarding the third concern, which is longevity, I think most of the valves can be used, but I would say that depends a lot on the patient anatomy. Considering also the NI calcified anatomy, I think the interannular devices are the ones that ensure a proper expansion and also the absence of PVL. And finally, if you think about the pacemaker implants, of course, usually the short frame valves are the ones that are preferred. I'm sorry that it does not go forward at this stage. But, and finally, if you think about the LVOT calcium, that favors as always the self-expandable platforms. And having said that, I thank you for your time, and I'm ready to take some questions. Thank you.
So Roy, thank you very much for your brilliant presentation. It addresses clearly the title of the presentation itself, and you already answered many questions that came out from the audience. So let me please go and ask David to take us through his talk about matching valve design to anatomy. Remember, this session was built by Nicolas, where the one improves and prepares the other. So please, David, it's your turn now. And we are all ears for you.
Okay, thank you very much. So I'm going to talk about valve anatomy. I thought, how am I going to give a talk at the end of these 4 talks that doesn't repeat what other people have done? So what I thought I'd do is take people through a very practical approach to matching the valve to the anatomy, as in the title. And I'm going to digress momentarily. I know I've only just started, but I'm going to digress for a second about age. Joanna brought this up, but it's a very important point. The guidelines focus on age, but really, that's not what's important. It's expected longevity that's important. The question being, of course, will they need a second TAVI? Now, we have to remember that in our practice with doing surgical valves, doing TAVI and surgical valves, actually that only constitutes 5% of our workload. So I think it's quite likely that it will only reach similar levels. For us, that means about 1 in 20. So in a program of 400, you might only do 20 a year. So I think it's important, but we shouldn't focus too much on the second valve and should still focus mostly on the valve at hand, as it were. So, you have different scenarios where people who are younger are actually biologically older, and therefore one may require a second valve, even though they're actually the older patient. So I'm going to leave that digression aside now and go back to the topic of the talk, matching the valve to the anatomy. So I do think the first decision is expected years. What age is this patient? How much comorbidity do they have? Are we going to be looking at a 1 or 2 valve patient here? Now, the majority are going to be 1 valve, and I'm going to take you through a sequence of, I think, binary decisions which we all have to make as we decide what valve to put in. And this is how I do it, at least mentally, as we go into a TAVI. So initially 1 valve or 2, and then secondly, it's a question, is this a larger or smaller annulus? Now you can choose where your personal cutoff is for that. It might be 75, 76 millimeters perimeter, 24, 25, possibly circularized annulus. But once you've made that decision, you then are faced with different imperatives for what valve you're going to put in. So here we have now going down the larger annulus route. On the CT, we either have a favorable or welcoming annulus, or we have a hostile annulus, and they will be very different in terms of the decisions that you make. So if you have a larger annulus and it's hostile, so you don't want to take the risk of having annular rupture. There's no need to take that. We've got good platforms where that's not necessary. So if it's nodular LVOT calcium, then that actually fits the Navitor quite well because of the semi-lunar parachute type edges around the outside of the valve, which will hold on to any blood that's trying to be regurgitant and will limit any paravalvular leak. So that actually works anatomically rather well. If you have linear LVOT calcium, like a waterfall or plate of calcium there, you could probably use either of the major self-expanding systems. So that arena is not too difficult. If you go down this other route now with a large annulus and a good anatomical annulus, well, to be honest, any valve will do. And actually, most people will probably choose a balloon expandable valve. There's no reason why you shouldn't choose self-expanding, but in practice, most people choose balloon expandable here. Then if you look at the smaller annulus group, you are likely, we are likely, to choose the self-expanding valve. We want the best hemodynamics out of the valve that we can get. And that will be better with the self-expanding than a balloon expandable valve. And then the specific choice varies according to maybe smaller detailed stuff, pacing, pattern of calcification, coronary access. Moving on then to the slightly more difficult scenario of 2 or more valves. Again, mentally, you would approach this by saying, okay, is this a smaller or a larger annulus? You can choose your mental cutoff for that. Let's look at the larger annulus first, and again, divide it into hostile or favorable anatomy. If we do that, then again, the favorable anatomy lends itself very well to balloon expandable valve because, of course, it's going to be quite easy to do a second valve should you ever need a second valve. And by the way, if anyone wants me to do their illustrations for their journal stuff, do get in touch because obviously it's my forte. If, on the other hand, you have large adverse anatomy annulus, you're going to be looking at potentially the need for coronary risk modification when you come to the second valve. So in that setting, if it's unlikely anatomically, then of course you can choose either. But if it's more likely, then you're going to choose the Navitor, because it's an intraannular valve. The more supraannular the valve system, the more likely you are to have to do complicated things to obviate the risk of coronary occlusion second time round. And then we get to the most complicated situation of all, is where you have a likely 2-valve lifetime strategy and you have a smaller annulus. Here, you have a Russian doll phenomenon. If you put in balloon expandable valves here, they will get progressively smaller valve areas, as Nicolas showed us earlier. So that's disadvantageous for the patient. If, however, you have a hostile annulus with a small annulus, you're going to want to put in a self-expanding valve. And again, bearing in mind the possibility for leaflet modification at a distance, you're very likely to want to put in an intra-annular valve rather than a supraannular valve. So I would say in summary, obviously this is a multifaceted and complex process, which I've divided up into a series of simple binary decisions. Of course, it depends really on the patient's expected longevity rather than their age per se. Depends very much, in my mind, on the annular size. That gives you a quick demarcation into the likelihood of balloon expandable or self-expanding. And absolutely, it depends on the hostility of the annulus with any left ventricular outflow tract calcification. And actually, we're very lucky. All patients really at the moment do have an optimal choice from amongst the various providers for their particular anatomy. Thank you very much.
Thank you very much, David. And thank you for taking us along this mental exercise of how to navigate through the landscape of contemporary transcatheter valve designs, because there's so much out there. And I think you gave a very nicely illustrated overview on how to approach this. Unfortunately, in the interest of time, we need to end this session. We are well above the allotted time. So I would like to thank Joanna, Rui, and you, David, and also a special thank you for Thomas for co-chairing and also for the kind hospitality for TIO 2026. With that, I will now hand over to Azim, who will be chairing the next session on procedural and advanced imaging. Thank you very much.